Good day, everybody. As usual, after ASH, we are having a little round table here with Professor Ruben Mesa and Professor Serge Verstovsek, which this year again, they are both, attending our request to explain us a little bit, how was the ASH and what news can we expect from there. I know that Ruben has a little bit a timing problem. He will have to leave a bit earlier. So I just wanted to say something which I wanted to explain at the end, but I want to bring it up now. I'm a PV patient and I've having since 35 years. Now, I wanted to say some words on the Beutel Prize award when you got the award there, but it wasn't possible. So I just would like to say it now. I always said that in 35 years ago, the MPN world was like a dark hole, a black dark hole. But I have to correct this. I would say it was a dark sky. And in the meantime, today, at least what we have a clearer picture. It's a little bit of light. We have no moon, which would be a chronification, and we have no sun, which would be a cure. But we have a lot of new um, treatments which came up, which bring us some light on this sky picture. And this is only thanks to the work which the two of you and all your colleagues have been doing in the last, was it now 20, 30 years approximately. Thanks to you, we are having these new treatments. And just in the name of all the patients, I wanted to thank you and your colleagues for all the efforts you're continuously making. You are only hope, but one day we will get also the moon and the sunshine. I'm sure it will come. It's a question of time. And your dedication to us patients is great. And I just wanted to thank you very much. This is what I actually wanted to tell you at the end, but I thought to bring it now. So welcome both of you, and thank you for being here.
Wonderful. And let me share, Peter, for those on here, to realize one of the things that I think is unique and special about the MPN community is what a significant role really patient advocates like yourself have really played in this process. So I think, and Serge, I'm sure can back me up on this. A lot of the progress that we have really made, whether it's understanding the disease, symptoms, people who've generously participated in clinical trials or survey-based research, advocated to our colleagues in the pharmaceutical industry or to regulators. The progress would not have been possible really without really a partnership. So thank you for all you do in that, again, you try to really help decrease what patients are going through by education, by understanding, by trying to alleviate that anxiety. So thank you very much for everything that you do.
Thank
And just to congratulate Ruben one more time. It was an amazing and well-deserved prize. Thank you so much for everything you have done over decades, Ruben, with us as a part of the team. Peter, your efforts and the patient's efforts are incredible. We together as a team, we have changed the outlook of patients with MPN, changed the way that the medications are being developed, and leading the new wave of targeted therapies for patients with MPN that we're going to be discussing today. So it's amazing journey over the last couple of decades. Thank you, everybody.
So I think after all these good words, we can go home, no? That's all we want.
No, no.
We've made good progress, but there's important work left to be done.
Absolutely, yeah. So listen, I didn't see many of the presentations as usual. I was running from one pharma to another. Why don't you two just explain a little bit, what's going on, and maybe giving a bit more preference to Ruben because he will have to leave. Why did you start, Ruben?
Well, why don't I frame a little bit, kind of my takeaways in terms of kind of areas, and then we can kind of to tackle them kind of one by one. So of course, when we're thinking about patients with MPNs, the needs are variable. We really have earlier disease, polycythemia vera, essential thrombocythemia, where again we have an impact in terms of risk of blood clots, symptoms, a risk of progression, and we build from a base of historical therapies such as hydroxyurea, anagrelide, interferons, and ruxolitinib and PV. And then we, of course, have the more advanced myelofibrosis that, again, can be quite variable how it impacts folks, but again, has a range of challenges and important as we think about how we assess therapy. So I think in many ways we had, a very active ASH with a lot of important things to discuss. What I mean by an active ASH is, again, Serge and I having been in this field now for many years, decades. When we started, there was typically only, one section of ASH really dedicated to MPNs. There would be both presentations that were kind of given verbally, what we call oral presentations. These are the most impactful. And then, a limited number that are presented in kind of a big hall as posters that are important, but again, kind of a broader piece, but probably less exposure. This year there were probably, I think, 6 or 8 different oral presentation sessions as opposed to where we used to only have one. And then posters that have to occur on all 3 days of the meeting as opposed to where they are one. So there were hundreds of projects submitted that, again, each one representing a clinical trial or other pieces. Now, I think takeaways for folks is, one, there's really updates in terms of new therapies as they relate to ET, therapies and updates as they relate to PV, and then in myelofibrosis, many as it relates to maturing data for our current JAK inhibitors, combinations or new agents under investigation, and then even a new wave of now agents that are more specific for the targeted mutations. Serge, kind of what were some of your high-level takeaways before we start discussing perhaps some of the updates in ET and PV?
Well, the number of sessions, as you pointed out, has increased so much that you can't even make to all of them. They overlap. So you couldn't really get to hear all of it, not just because you're busy meeting colleagues and discussing projects, but just because the schedule does not allow you basically to be in 2 places at the same time to hear the oral presentations. So you have to catch up and really be on top of everything to get the core of the oral presentations. What do they bring to the field? In general, in terms of the significance for us in the field, I think that what I mentioned kind of briefly, targeted therapy, the therapies that really try to counteract the malignant cells, or we call it malignant clone, by bad cells in patients with myeloproliferative neoplasms, have taken the center stage, right? The calreticulin targeted therapies have been presented in oral sessions multiple times. 4 or 5 of the sessions had contained presentations from different investigators or companies on attempt to develop or even test already medications that would eliminate malignant clones, cells with the calreticulin mutation on the surface that you can then target and eliminate. That, to me, that center stage of targeted therapy is just an example of calreticulin positive cells is major development for the field. Not that we have the answer right away, what therapy will be doing to the patients or what have they done, the safety and efficacy and all these other different attempts to eliminate those malignant cells, how they're going to play out. Just the fact that we are at the new beginning, truly right now, with so much effort to understand how to approach that particular group of patients with calreticulin mutation is earth-shaking to me, right? We are focusing, trying to eliminate malignant clone. And maybe, Peter, you were talking always to me about the cure. Can we envision elimination and complete elimination of malignant clone in the future in patients with calreticulin mutation?
Let me just build from that because I think Serge brings up, I think one of the things that is the most exciting for those couple reasons. One, up to this point in time, we have identified through the work of our laboratory scientists that we have these three driver mutations that are mutually exclusive for the most part: calreticulin, JAK2V617F, and MPL. But our therapies have not really been specific to one of those mutations. The JAK inhibitors have been helpful in all three. Interferons can be helpful in all three. This focus on the calreticulin is exciting. One, because we may have truly that greater specificity, because as Serge mentioned, with the mutated CalR being on the cell surface, we may be able to truly target only the affected cells and not the normal cells. And that, in many ways, in cancer therapies, is the holy grail. Can we only affect the bad cells? Because when we affect all cells, that's really where side effects and inadvertent consequences of therapy really arise. Folks watching this, as you realize as we highlight what's at ASH, there's this kind of evolving field, some of which is kind of, part of the way ready and it's able to be discussed in an open forum like ASH. Some that are early in development, there's perhaps not an updated ASH, but we're waiting on updates to come forward, or mature phase 3 trials that are ongoing, what have you. There's now numerous approaches to trying to target calreticulin. And if so, really might make an impact. We heard some of the preliminary data, still very early on. They're still trying to find the optimal dose. But for this calreticulin strategy with a monoclonal antibody from Incyte, for both patients with CalR mutated ET as well as CalR mutated myelofibrosis. And there's other approaches out there going on in parallel. There's a bispecific antibody trial going on from Johnson & Johnson that they didn't have data at this year's ASH yet, but that'll be coming in the future, no doubt. And then there are numerous other kind of calreticulin things in development. There have been immune cell therapy type trials that have been reported in the past with CAR T. There have been vaccine-related trials. So definitely one of the most exciting things.
Yeah, so just to complement what Ruben has reviewed is, why do we need so many different options? Because we don't really know which one of the attempt, one or the other, will work and to what degree. What we know so far from the preliminary results of the antibody from company Incyte, antibody is the medication you give it intravenously, it goes around the body and specifically binds to that mutated calreticulin and eventually would affect the function of that cell through dying or not renewing. It would have some positive effect. That's our idea. You can modify that antibody in different way to perhaps kill it fast or faster. And other attempts that Ruben has reviewed are underway. And why do we need that again? Is because so far we know that we can actually target that cell with that antibody from Incyte, and there is decrease in the number of malignant cells, but we don't really know exactly what will this do clinically to a patient. Is this going to lead to normalization of the blood cell count? Is this going to decrease the spleen size in patients with myelofibrosis or improve quality of life? And if it does, the early signs are, yes, there is some improvement. To what degree with different attempts? So we are in this exploratory phase with a lot of excitement, a lot of different venues or avenues to tackle the calreticulin mutated cells, but we don't really know where we're going to be ending. So that's the exciting part forward for us.
So other key things I would highlight in the ET space, one, there were further updates really as it relates to ropegulated interferon. So I had presented earlier this year a global phase 3 trial, the Surpass ET study. And then at ASH, Jean-Jacques Kilajan presented a study. I forget the acronym, but it was a similar a ET-focused trial of ropegulated interferon with investigators from Europe. And both I think were very consistent that, ropegulated interferon now approved in polycythemia vera, not unsurprisingly, is also very effective in ET. Helps to control counts, can help to decrease the mutant allele burden, uh, likely decreases the number of vascular events. There tend to be fewer events on these studies, so that's a little tougher to prove in absolute terms, but certainly that trend is favorable, as well as certainly favorable compared to controls. In the SURPASS-ET study, that control had been anagrelide. Anagrelide is a therapy that can lower platelets, but there's limitations. It has toxicities, and probably has less biological impact on the disease, than an agent like interferon, which really may have an impact on the stem cell. So I think those are very favorable data, and again may well help to kind of make the case for really the expansion of kind of formal approvals in various countries, from just PV for ropegulated interferon to ET. What do you think, Serge?
Yeah. So finally, we have the interferon at the cusp of being approved therapy for patients with ET based on SURPASS study and other studies that Ruben mentioned. This is a long time in the making, right? The interferon has been around in different form and fashion for so many decades, and finally we have a proof in formal testing for regulatory bodies to say, yes, it works and it's going to be approved in the United States and in Europe, I hope, in a very near future. We can extend, and just to mention, it was not presented at ASH, but we can extend, highly likely, the activity of ropeg interferon in patients with very early stage myelofibrosis. We call it prefibrotic myelofibrosis, or early stage myelofibrosis, where the main problem is not huge spleen and very bad quality of life, but because it's early stage, the patients still have a high blood cell count, high white cell count, or high platelets. And in that setting, the ropeg interferon is being tested again for possible approval. So I can see easily, we can all see that from polycythemia vera to ET in very near future, where we expect approval, we will have down the road in perhaps a couple of years, results of the phase 3 study, randomized study for possible approval of ropeg interferon in early stage myelofibrosis, which all makes sense. So very exciting for a larger community of the myeloproliferative disease patients, because it spans all three types to a great degree. Now, if we move to polycythemia vera, where interferon is approved, as is ruxolitinib, and the hydroxyurea is being standard practice as a first-line choice across the globe, the pending, I would say, and Ruben may jump in here, possible approval, I would say pending approval of rusfertide, the hepcidin mimetic for control of the red blood cells and the quality of life, is exciting, because it's another approach, although quite different than anything else we have seen so far. And along these lines, other similar drugs are being tested in the clinical studies to bring perhaps even more scrutiny to our ability to control well the red blood cell count in particular in patients with polycythemia vera. How do you see, Ruben, in your view, the application and adoption of hepcidin mimetic, that's what rusfertide is, which we think will be approved in very near future?
So it's a good question. So one, I think that it does clearly, fit an unmet need. As I think about phlebotomy as a therapy, it's really an ancient therapy. In the past, we used to take blood off for any number of illnesses. And over time, that really has decreased because we really had more specific therapies. When George Washington had a severe infection, which ended up taking his life, back in those days, they would do phlebotomy, again, and it was harmful. In P. vera, it's had value, but again, it's a very, very non-specific kind of physical therapy with negatives. And I think the negatives of phlebotomy are one, it causes iron deficiency, which can worsen the symptoms associated with the disease. Two, it's a very uneven control of the disease because someone's blood counts are rising and then they get phlebotomy and then they're rising again and they get another phlebotomy, up and down. There's kind of this cyclical nature to their blood counts, and with that, there's variable protection against blood clots by hematocrits being higher than really is desired, and two, the way it affects patients' symptoms. So I think there's multiple limitations to just phlebotomy alone. So the hepcidin mimetic, as making individuals not require phlebotomies, has a plus. It can have an even control of the hematocrit so that no phlebotomies might be necessary. And as a consequence of that, the iron deficiency that had been present before can be corrected. That again can have an impact on fatigue, can have an impact on symptoms, might have a value in terms of more even control against risk of blood clots or bleeding, and again, may have some other benefits. By needing less phlebotomies, will someone be less likely to progress over time to myelofibrosis? I don't think we know that, but we don't fully know why people progress to myelofibrosis. So it's possible that there could be some long-term benefits. The trials had been for individuals that needed phlebotomy, and this is the important part, that it's not instead of cytoreductive therapy, but sometimes in addition. So there were two groups. One, people who needed phlebotomies but were not on cytoreductive therapy, hydroxyurea, interferon, etc. Or two, individuals that were on cytoreductive therapy but still needed phlebotomy. So again, there are sometimes people are on a certain dose of interferon, raising it higher, may not well be tolerated, or their white blood cell count may be also affected by their therapy so that there's really not room to dose escalate their hydroxyurea or their interferon, but they're still needing phlebotomies. So a better way to kind of control that. So I think it'll be an impactful therapy. There was also presented this year's ASH an additional agent that I've been involved with that's earlier in testing, but slightly different mechanism of action, trying to do the same thing in some ways, sapablursen, which is a TMPRSS6 inhibitor. So now there's a couple in this space, but rusfertide quite a bit further along in its development, with the positive phase 3. I think if approved, you would find that, again, the national guidelines committees in various countries, in the US, that would be NCCN, would gather together to see how exactly it fits, as well as, in certain countries, there certainly might be a health economic analysis as well, just to see kind of, where it fits in the armamentarium, kind of based on, expense of the medication and other pieces.
Just to add a few words about the mechanism of action and what does this really mean clinically then. So we talk about this hepcidin, right? Hepcidin would be main iron metabolism controller, or a protein that would guide how much iron is available in the body. And hepcidin is very low in patients with polycythemia vera. And that's why we talk about rusfertide being mimetic, right? You give it and mimics the hepcidin, and that's what it does. It controls the iron metabolism and normalizes the iron levels. And with that, it would normalize the red blood cell count, no phlebotomy anymore, improve quality of life. The other medications that you mentioned, parsaclisib is hard to say, works a little bit different by increasing hepcidin by the body, right? Makes the body produce it more, right? It makes, this is with the same goal, but a different mechanism of action. And perhaps it's a little bit different in terms of how often it needs to be given. Rusfertide is given under the skin as an injection every 2 weeks, and the new medications perhaps even every month or every few months. So we'll see what happens down the road. And I think the other point that you made, that rusfertide might be used in many patients in combination with other agents, because rusfertide would control the red blood cells and the symptoms, but then you still have high white cell count and platelets in some patients, as well as big spleen. So maybe in combination would be the best options for many PV patients. Peter, you have listened to us. What is your comment of what we have said so far on ET and PV?
Well, I think it's very, very promising developments which we're having. I like special rules for TD. I think this is for many patients, they have big problems in phlebotomies. So they are very, very happy that something is coming up. And I'm personally very happy about, the interferon products that you're trying to find out how is it reacting in MF, which I think, as I agree with you, I think it should be positive, and I think these are, very, very good news. But I have 2 or 3 questions, but I will come at the end. Yeah, I would like to use Ruben's time as much as possible as he's still here.
Well, why don't we pivot then to MF and then can circle back after I have to rotate off in just a few moments. But in MF, I think a lot of exciting things, as well as I'll share there are important phase 3 clinical trials ongoing at the moment that we don't necessarily have data from each of the trials at each of the meetings because there are things that are ongoing. But one, of course, there was that CalR inhibitor. The data in myelofibrosis was very interesting. It helped to have an impact on spleen symptoms, the allele burden for calreticulin and anemia, and in some ways that's a very exciting portfolio of pieces. Yeah, it's an early set of data, and what I mean by that is that it's an aggregate of 2 studies, and patients have been treated at a range of different doses. So it's very difficult for us to know what is the kind of likelihood that a patient has benefit. Always, of course, depends a little bit on dose. So the first phase in any sort of trials are, again, trying to find the dose, see if there's benefit, but then you get a better sense of activity after that dose. Next, I'd say in terms of things that are exciting, one, further mature data with the combination that at this point has the most mature data, which is pelabresib and ruxolitinib, from the longer term data from the Manifest study. And this continues to show, very significant response rate, particularly for splenomegaly, for patients with myelofibrosis, maybe double that what we had experienced historically for ruxolitinib alone, as well as probably some net benefit of additional symptom burden. Probably not dramatic, but certainly no worse, probably better. So that again, that is moving along. There's additional data that's being generated, but that could become one of our first approved combinations for individuals. Additionally, there was data with luspatercept. There was information of luspatercept with momelotinib in the early setting to help to try to improve anemia. And if you improve anemia more, will that have a greater impact for individuals? So those were some of the things I think that were kind of top of mind. There's also really trying to leverage, mature drugs that we have at the moment. There was a nice study done out of the UK called the Fedora study, led by Mary Frances McMullen, where they use both fedratinib and ropegylated interferon alpha 2b. And that, in ways, kind of builds off of the ruxopeg study that Jean-Jacques Kilojan had done with ruxolitinib and ropeg interferon alpha 2b. There's a current clinical trial, the HOPE MF study, that I'm helping to co-lead for patients as a monotherapy with ropeg interferon alpha 2b for patients with earlier disease. So I still think the interferons will play some role, I think, in multi-drug therapy for MF, whether that's early patients, whether it's in combination for later patients. Clearly, I'm very excited for Serge's upcoming study. We didn't see data on it yet because it's just accruing with naftamadilin and the POESIS study as an add-on trial. I'm very excited to see where that takes us, Serge. But of course, that study is still accruing, so no information on that yet. But the things that were presented, what were things that really, caught your eye the most, Serge?
I think the spectrum of developments that lead us to different directions is exactly what is exciting. It's not just one path forward. We talk about calreticulin. Okay, that's one path in myelofibrosis, and it may have some limitations actually, targeting calreticulin mutated cells, because in myelofibrosis, as we all know, the malignant cells multiply in different directions, acquire other mutations, and I many times talk about the clonality, or multiple different clones of malignant cells with different characteristics being present in one person with myelofibrosis. So to make it simpler, it's like a Star Wars. The clones are fighting each other and which one will survive. And targeting only one with a calreticulin mutation may not do everything that we would expect from medications for myelofibrosis. Perhaps combinations again in the future will be needed with that attempt. But other less specific drugs perhaps may have a more effect. And you mentioned pelabresib, that's a BET inhibitor. BET inhibitor allows genes to be active again and may lead to cell death, malignant cell death. You mentioned also our own study where we add, like pelabresib, on top of ruxolitinib, standard JAK inhibitor, as a first-line choice across the globe for myelofibrosis patients. Our own study adds a medication called naftamadlin that you mentioned, which inhibits a protein called MDM2. That again leads sequentially to malignant cell death. That study is underway, you are right, in the middle of accruing 600 patients around the globe. But there are other combinations. The other combination that was presented in oral session is with PIM inhibitor. Now, what is PIM? That's another protein that is important for signaling inside the malignant cells and normal cells, but more so in malignant cells, that leads to inflammation and the growth of the cells and the symptoms and the growth of the spleen. So that medication, PIM inhibitor, is being combined with momelotinib, not ruxolitinib, momelotinib this time. So that was another oral presentation of very interesting combination. So calreticulin, targeted therapies, combinations on top of ongoing therapy with the JAK inhibitors. And then you mentioned briefly also anemia-targeted agents, right? Luspatercept is one that is being combined actually with the JAK inhibitors. The other one has another difficult name, elitercept. My God, very complicated name. From company called Keras. These are injectables under the skin every 2 or 3 weeks to increase the production of red blood cells. And then another medication from company called Disc Medicine with the same idea, to have anemia drug that you can combine with the JAK inhibitor or any other medications to help patients suffering from anemia. So areas of interest, combinations, anemia drugs, calreticulin, these are the 3 areas that are obviously blossoming. And then new ideas of medications targeting completely something novel that are earlier in the stage of development.
Wonderful. Well, I'm going to need to run. My apologies, but I left this year's ASH with really a tremendous sense of hope. I was able to give a talk at this year's ASH, and one of the things I had mentioned is, when I started my career, we were largely having to, leverage therapies in clinical trials really without a good kind of molecular scientific underpinning as to why we were using them. And they weren't very effective, and we really were trying things based on our best guess, based on aspects of the disease, whether it was scarring in the bone marrow or targeting blood vessels in the bone marrow. And now I think hand in hand, we really walk a path of scientific discovery, whether that's mutations, whether that's additional somatic mutations, whether that's other aspects of the biology of the disease and why it progresses. and then the development of therapy. So very excited for the future, and wish everyone on here both health and happiness for the new year.
Thank you very much for being here. Yeah.
Thank
Bye-bye.
you.
Thank you both.
Have a good year. Thank you. Okay, Serge, you and me are alone again.
Well, that was wonderful discussion. And just another word about the efforts in the myeloproliferative neoplasm field, that particularly Ruben was a key person, and that was very satisfactory for us all to have Ruben then be recognized as a main leader in the myeloproliferative neoplasm field and receive such an outstanding award. Just give you perspective. 20 years ago, we met for the first time, all us younger than what we are now, much younger with different hair color, in Houston. And we said, what is the benefit of any therapy to patients with myelofibrosis? And we didn't even have a JAK inhibitors. We didn't recognize that as valuable yet at that time. It was early on in development. And we said, okay, decreased in the spleen must be beneficial, must be. It's smaller organ. How do you prove that? We didn't really know, but we said it's beneficial. Then improvement in red blood cell count, obviously improvement in anemia, improvement in the platelets if they're low, improvement in the white cells if they're low because you get infection. That's about it. And then through development of JAK inhibitors, we obviously recognize that quality of life improvement is such an enormous benefit that we overlooked. That's critique of investigators at that time, myself included, that we couldn't really objectivize what the quality of life of patients is. This is where Ruben stepped in and developed with the colleagues and the team what we now commonly use all the time, a questionnaire, right? Myelofibrosis or myeloproliferative neoplasms, specific questionnaires with the most common questions about, or most common problems that are questioned about in everyday practice or in clinical studies, and help develop new medications. So amazing, amazing development led by Ruben that was led to this amazing award as well, but made such an impact on the field. So let's remember where we come from and what happened. Yeah.
I think this is very important. I tell many times to patients that we have been coming for a long way, and it's absolutely amazing. Such a small, rare disease. How many excellent people is working on that, how many industries is working on it. So I think in this sense, I think we're very, very fortunate. Now, if we come back a little bit to the ASH results, I would say there might be, if I understand well, maybe three main streams. One is for calreticulin, which is now trying to get through for ET. Once it's getting through there, I hope you will also find ways to for PV and for ET. Then we have our cytoreduction products, which we have already. Some, maybe one or two more will come. And we are working now, or you are working, you as a global physicians, researchers, you're working on combinations. We had intensive combination products 2 or 3 years ago, and it was not very successful. I hope this time it looks very promising for a few of them. And then I think the most important, which I consider, is that we have these treatments which are attacking the malignant clones, as you have been mentioning. And I think this is really, I could say, the cytoreduction period of time is over, and we're going now to a malignant clone productions over. Is that a little bit a good synthesis of what we have been talking so far?
Yes, perfect. I think this is exactly where we are right now. We are at the end of a wave of non-specific medications, a wave that led to multiple phase 3 randomized study for possible approval of those medications that unfortunately, a number of them did not make it, as you heard and as you just said. But there are still efforts to develop combinations particularly combinations with the medications that would complement what the JAK inhibitors do and enhance or optimize patients' care with that combination, like with what was mentioned, pelabresib or the naftemadlin. But the field is moving to the next wave, and that is the targeted therapies that we talk about a lot, and there are multiple attempts to target the calreticulin because mutation is present on the cells and you can target that cell specifically. There are also efforts to develop, which has been hard and is still hard, JAK2 mutation-specific drugs. There are some attempts that are being made to try to devise medications that would inhibit just the mutated the JAK2 protein. Now, why is that important? Because everybody has the JAK2 protein in their body, in their cells, and occasionally it gets activated when we need to make blood cells. It has other roles, but let's talk about the bone marrow and blood making. So you and I, when we need to make a blood, the growth factors, that's how the proteins that go around the body are called. They go around the body and stimulate the bone marrow cells to make blood, and JAK2 protein is a very important factor for that. In the myeloproliferative neoplasms, in many of the patients, majority, the mutation in the JAK2 protein leads to uncontrolled growth. That's we know. All the JAK inhibitors that we have so far are not specific for the mutation. They just inhibit that continuous signaling, and that's why the number of cells decreases, like in PV, the spleen decreases, like in myelofibrosis, quality of life improves, but there is no specificity for the malignant clone, again, the malignant cells. And the efforts are underway to develop JAK2 mutation-specific drugs, which has been biochemically, I understand, extremely hard to do. That this mutation is inside the cell, it's not on the surface that you can see it. You need to develop some specific unusual drugs to get to it. But the calreticulin is pushing forward, so others are following and say, hey, why don't we try again to try to develop the JAK2 mutation-specific drugs, and hopefully that will happen as well.
So a specific JAK2 treatment is not
Mutation.
the same as the malignant clone, no? Clone.
For the malignant clone, JAK2 mutation-specific drug that would attempt to eliminate malignant cells with the JAK2 mutation, because current JAK inhibitors don't do that, right? They just decrease the growth of any cells. Malignant, no malignant, doesn't really matter, right? If I take the ruxolitinib, I would eventually, at some point in time, depends on the dose, develop anemia and thrombocytopenia because it inhibits normal as well, right? So they're not specific for the mutation. If we could develop the mutation specific, then we would only affect the malignant clone and malignant cells with the JAK2 mutation. That has been very hard. But hopefully that the renewed interest in targeted therapy, as evidenced by the calreticulin drugs that are in development, will lead to efforts to, again, to develop the drugs for JAK2 mutation specific JAK2 mutation targeted therapies. Remember, the calreticulin is only present in about 25 to 30% of the patients, so we still have
sure,
70% of the patients that have a JAK2 mutation, right? If you have a MPL. So it's still exciting time, and we'll see what happens in the next few years as these medications are developed. We still don't want to forget the standard non-specific drugs, new combinations, everything that we talked about it. It's a continuous process. We don't change from one to the other. Evolving. The field is evolving as we learn more about biology, and our attempts biochemically and pharmaceutically are evolving. New techniques, new ways of developing drugs, as evidenced by targeting calreticulin mutation.
Thank you very much, Serge. Yeah. Well, I think this looks very, very promising. And, about the combinations, what we can see also is that many physicians, were actually doing these combinations by helping some patients who do have a specific problems to give them two different medicines, which we are having at this moment. So, if let's say some patients, they are running very well on one of the interferons, but the spleen is not reducing, so they help with a little bit of Jakavi and to get the spleen down. So I think, many physicians are already going to that way to have a certain, way of combination of a product. And I think this will give us also information, how these combinations could work out. And, that's why it's very important that we all work together and we get as much information, from a patient, what is really happening and how, for example, these combinations done by the physician, how is that working?
You see, I mean, this is excellent example because combinations in treatment of polycythemia vera have not been common, not even an idea, right? You would go with hydroxyurea, if it doesn't work, you would do some other chemotherapy like busulfan, or you would do interferon, the old-fashioned ones, or then ruxolitinib as a second-line choice. And now you gave an example of combination of interferon and ruxolitinib in some patients, and we just talked earlier on about rusfertide being a combination partner on top of other agents, right? In PV, we are talking about combinations in polycythemia vera, which was not normal so far. Adding an agent to completely eliminate phlebotomy, improve quality of life, let's say on top of hydroxyurea, that hydrea would be controlling the white cells and the platelets and the spleen, right? So two together would be optimizing the care of the patients. That's a tremendous new development for polycythemia vera patients. There are many more of PV patients than myelofibrosis. And perhaps in the ET, we will see that too in the near future. We are not there yet. Yeah, so that's that evolution of the thinking and drug development, and all for the benefit of the patients to control the disease, optimize the control of the disease, potentially eliminate over time, for patients to enjoy good quality of life as long as possible. For ET and PV, prevent progression, right?
Sure.
So, yeah.
Well, I think it's, the physician in the past, he normally had a patient of 60 years old, and his job was to have him alive for another 20 years. Today it's a bit different. We have many young patients. They are 20 years old, and you have to find a treatment which keeps them alive 60 years. And keeping alive, I mean, in, acceptable quality of life conditions. So, I think this is a complete different changing. And, I'm sure also researchers, they know about this. And, they have to look for treatments which simply start from a different point of view from a treatment. Do I want to keep a 60-year-old man or woman as long alive as we can? Or do we really have to look on now treatment? And we do have to look for treatments for young people, which is totally different.
A very important point, right? As we are able to now to identify the disease earlier on through molecular testing, to paying attention more, and that is also driven by new therapies that are being available for the patients, then we realize that these are not diseases of the older people. It's also seen very much in patients with a younger age, in ET and PV in particular.
Sure.
And so then that question that you raised is very important for future thinking about what drugs to use, right? You don't want to use very intensive chemotherapy in young people because it's harmful. That balance between the positive and negative in any drug has to be accounted for person by person or patient by patient. Who are you talking about, right? And so that individual approach through drug development and ability to use multiple ways of managing the diseases will be modified based on the patient's characteristics, age being one of the most important ones.
Yeah. And we always say that each MPN patient is different, but I assume that's in other cancers it's probably the same thing. But we will at the end we will have to look for personalized medicines, but this is two steps ahead. So let's
Yes,
let's talk on what we have for a moment. Well,
Mhm.
we didn't want to keep it longer than 45 minutes. We are already at 50 minutes. May I just, come back to one point which we very briefly discussed in at ASH, and it's the famous TSS 50. you are doing a fantastic job in getting up new products, and then apparently there are new rules for the administrations who are applying this question of a TSS 50, which means that any new product would be 50% better than from a patient side point of view, and that basically means if a product is 49% better, it's not accepted anymore. And you told me a very good question when it says, why don't you ask for TSS 100, which definitely should be the goal.
Okay, yeah.
It
So
was a very, very good question, which made me think a lot, actually. I can't tell you.
just to put that in perspective, so we talk about amazing work that Ruben has done with others involved in the field of developing a questionnaire, right, to objectivize the quality of life of the patients, being ETPV or myelofibrosis. And with that questionnaire, we can then say, what is the quality of life on a certain scale? And that gives you a score, basically. And you say, if I can improve quality of life 50%, that is TSS 50, what you are talking about. Total symptom score 50, TSS 50 means half of the symptoms gone, right? TSS 50, that's the abbreviation for total symptom score 50, meaning if the score was 28 and you go to 14, that's a success. And all right, and that's then one of the goals of the therapies, right? We say half of the spleen gone or half of some other measure, we don't have it, but we talk about the spleen. We say TSS 50 is the goal of the therapy, and that will, if successful, proven to work with the new medication, can contribute to possible approval. And so many, unfortunately, not many, but a number of clinical trials in myelofibrosis over the last year and a half did not succeed because they did not show that the investigational agent is better on TSS 50 than the control arm without medication, without placebo-controlled randomized blinded studies, right? So TSS 50, there was no much difference, statistical difference between the two arms. And so the argument goes, why don't we lower the bar and say, okay, how about 40% or 30% improvement in the symptoms? Why not use that? Well, I don't agree, as I said at ASH. Why don't we increase the bar and aim to develop medications that actually do the job, right? The job is improving quality of life. If I am a patient and I am so sick and half of my symptoms are gone, I will ask my doctor, how about the other half? I want 100%. I would not settle for 20% improvement in quality of life or 40. I want more than 50. To me, 50 is not good enough. That's my view, but of course, that's why we discuss it, right? And smile to each other, because I would like to push for more. And perhaps the drugs are not good enough, or design of the study is not good enough. Maybe the drug is being tested in a patient population that really doesn't need improvement in quality of life, or they're not sick enough to show that benefit, right? Maybe the design is not good, maybe the drug is not good. There are different other ways of looking at the problem, not only by saying, well, how about we lower the bar and then get approved the drug for 20% improvement in quality of life.
No, I think nobody really would like to have it. A question which I've been talking with several patients in the meantime, and some of them have said, well, it would be a pity if a product is 49% better than the existing ones, and it's being rejected because it doesn't reach a 50. It would be a pity not to get it, because I would be, with 49% less of symptoms. Although again, that depends how his body is reacting to that product, which we don't know, and everybody has a different reaction. So I think it's a very complex question, but let's discuss it further. I think it's a very important point. I understand what you say with 100%, that there's no question that this is what we all need, and what we would like to have, that we have no itching, we have no bone pain, and we have, fatigue. It's very difficult because I think everybody is tired. So to get that rare fatigue from MF, to get this really very much done would be very important. But let's keep on discussing on that point. It's you woke me up on that one. Yeah.
Okay.
Okay. Well, I think that's it for today. Thank you very much. It was fantastic information which you gave. I fully agree with you that we can be extremely happy and very positive about what's going on. It's every year in ASH, it's getting broader and broader. The negative result is, as you say, that we cannot attend to all the presentations because we're overlapping. But I can only say it's amazing. We are such a small community, it's such a rare illness, and still we have so many good, excellent people working on it and trying to get the solutions for us. And again, thank you very much for what you're doing. Yeah.
Thank you, Peter, for everything you do and your team. It's wonderful to be engaged like this over decades. And there are many years in front of us together to see where the
Sure.
field will evolve. But yeah, this was wonderful. And Ruben contributed here so much.
Yeah,
So we look
absolutely.
forward to next year.
We repeat it. Thank you very much. Wish
Happy
you a
holidays.
happy new year, Merry Christmas, good holidays, and
Yeah.
let's try to take a little rest. Yeah.
Merry Christmas, everybody.
Okay.
Have a
Thank you
good
very
day.
much. Bye bye. Bye.
Bye.